Go ahead.
Participants know we're running a few minutes late. Let them know.
Yep. Everyone's here and ready for you whenever you're ready.
Okay, great stuff. Well, thank you. And I think I have my colleague Hani, who is with me here today. Hi there, Hani. Nice to share the platform with you. And good evening to all of our colleagues joining today. You would think in year 3 of the pandemic, we have all the technicals sorted out. So my apologies. Let's get started. The day is now longer. We've got our evenings, a bit of sunshine. We want to enjoy it. I'm Roger McIntyre. I'm a psychiatrist. I'm based in Toronto. I'm going to be sharing this platform with my friend and colleague, Hani Iskandar, a psychiatrist in Montreal. We're both psychiatrists, both affiliated with the CRTCE, the Canadian Rapid Treatment Center of Excellence, which was Canada's first ever center that provided care for depression using ketamine in the community, with 4 clinics located in Canada, 3 in Ontario, Ottawa, 2 in Toronto, and 1 in Montreal. So what Hani and I have decided to do is to really split the work, division of labor, to use Adam Smith's 1776 book quote. And we're going to talk about helping patients with treatment-resistant depression. I'm going to provide a 10 to 15-minute overview, and then Hani's going to take over. We're going to have plenty of time to take your questions, any comments that you might have. Let's begin with a definition, if we could, of treatment-resistant depression. There's over 12 definitions that have been identified in the literature. The United States Food and Drug Administration, and to some extent, Health Canada and the EMA, which is the European FDA, have embraced what's called the Face and Rush criteria, which has been generally referred to as the insufficient outcome on at least 2 antidepressants from 2 different classes. At CRTC, this is exactly the definition that we have embraced. That is, anyone with major depressive disorder, or for that matter, bipolar depression, who's not had a sufficient outcome as defined by clinician metrics, but also on patient-reported outcomes, who's not had a sufficient outcome with 2 treatments, would be certainly a potential candidate. And everyone joining us tonight, I should mention, we have almost 100 people signed up for tonight's program, are aware of the fact that when we look at conventional antidepressant treatments in major depressive disorder, the percentage of people who would meet that definition, that is at least 2 or more insufficient outcomes, is a very significant percentage, ranging from 30% to as high as 60%, depending on how we define it. The FDA in the United States declared ketamine a breakthrough treatment for depression. You all know that it was first isolated back in 1962 by Calvin Stevens just outside Detroit, and it early was introduced as an anesthetic, subsequently as an anti-pain medication, analgesic. It's well known to have anti-inflammatory properties, and more recently, its antidepressant properties have been described. Why it's considered breakthrough is for really 3 reasons. One is that it works exceptionally well with response and remission rates that we don't typically see with most conventional antidepressant therapies. Secondly, it works exceptionally well in people who are treatment resistant. They've had at least 2, but usually 6, 7, 8, even 9 or more prior treatments, including ECT and manualized based psychotherapy. Thirdly, it works rapidly, with benefits being observed within a couple of days of treatment. In fact, usually within 24 hours of the first infusion. But the point is that we have efficacy, we have a robust efficacy, especially in treatment-resistant and persistent depression, and we have a rapidity of onset that we don't typically see with our treatments. Now, there are many risk factors for treatment-resistant depression. These are just a few just to get us started. I won't go through an exhaustive list at the end of the day on a Monday, but we do know that people who are generally older tend to be more prone to treatment resistance. Treatment resistance is actually seen more in women than it is in men. And we also know that treatment resistance also more common in people who live alone, who are unemployed, and as well as people who've had depression for longer periods of time. In my clinical experience, treatment resistance also seems to be highly associated with comorbidity and especially associated with trauma history. In other words, people who have a history of childhood maltreatment, physical and sexual abuse, much more likely to experience treatment resistance with conventional monoamine-based antidepressants. The first, I think, message loud and clear, let's make sure we have the diagnosis correct. There's a lot of people who are told they have treatment-resistant depression, and they do, but it's not actually major depression, it's bipolar depression. So we want to make sure that we have the diagnosis established. And there's no doubt about it, people who live with bipolar depression do not respond as robustly or as predictably with antidepressants as do people with major depressive disorder. This is a screening tool, brief, patient administered, that really has good psychometric properties that you can implement, no charge, download it free of charge from Google at point of care to screen for bipolar disorder. Now, I really wish that in 2022 that we had a much more objective way to select and sequence conventional antidepressants. We don't. Still, we are relying on clinical experience, obviously what's available in the sample cover, what patients can afford. We're also relying on patient preference. And these are just some factors to consider. We have so many antidepressants in Canada, and we're picking medications often based on safety and tolerability. And we're also picking medications based on other factors like comorbidity and other concomitant medications. More recently, in the last, I would say, decade and a half, we begin to see now antidepressants. Some are more effective in treating select dimensions like cognition in the case of vortioxetine, pain in the case of venlafaxine, desvenlafaxine, duloxetine, smoking cessation and ADHD type features with bupropion, and a few other examples like that. I think taken together, though, I think it's clear that the great majority of people are not achieving the goals that they want to achieve with conventional antidepressants. When we do a pharmacoepidemiologic analysis, what emerges is that the type of treatments people often receive as so-called augmentation are not in accordance with evidence-based medicine. In other words, we have an implementation gap. We have a gap between what the evidence base states and what people actually receive. It's extremely common across Canada and the United States to see people who have not benefited from an antidepressant receive another antidepressant or receive a benzodiazepine or some other anticonvulsant. And this is common practice. This is data from Europe with a similar portrait as we would see in Canada. The problem with this approach is that none of these strategies are really sufficiently demonstrated as being efficacious in people who have insufficient outcomes to antidepressants. In Canada, the evidence base and the Health Canada indications which support aripiprazole and brexpiprazole. I tend to use more brexpiprazole than aripiprazole because I find brexpiprazole has less akathisia. I'm always concerned about tardive syndromes, including tardive dyskinesia. And of course, we're always concerned about metabolic problems. These factors and others have really undermined some of the acceptability of second-generation antipsychotics. So here in Canada, it would be common practice for patients to receive combination antidepressants. That's certainly not as rigorously studied. Second-generation combination antidepressants, second-generation antipsychotics, although shown to be effective, they also have some liabilities. When it comes to psychotherapy, it's quite common for us to hear patients state that they no longer want to take medications because they haven't worked and they would like to sort of cleanse themselves out and try psychotherapy. Well, I understand where they're coming from, but we have no evidence at all that psychotherapy on its own is effective in treatment-resistant depression. We certainly have evidence that in combination with pharmacotherapy, it's very effective in treatment-resistant depression. And we have a separate body of evidence which would suggest that if you have a history of trauma or multi-episode depression, certainly comorbid depression, manualized-based psychotherapies would certainly be able to offer a benefit when added to antidepressants. So CRTCE is not only interested in providing best practices at point of care, but we're also extremely interested at really providing guidance to clinicians around the world on how, in fact, this treatment should be administered. And many members of the CRTC team are authors on the world's first ever international guideline for ketamine and esketamine administration at the point of care. And I'd encourage you all to get a copy of these guidelines, which have been disseminated actually right around the world, and it provide guardrails for everything from not only why we consider ketamine a treatment option, but how do we select the right patients? How do we know we have the right personnel, training, and infrastructure? And how is the treatment actually provided? Very quickly, when we look at the evidence base for ketamine, notably IV ketamine, but also oral ketamine, and also intranasal ketamine, we have a very consistent signal of efficacy with an odds of responding that are significantly higher than we've seen before. Typically, remission rates with next step SSRI or SNRI are in the order of 5 to 10%, maybe 15% on a good day. We're getting remission rates with ketamine-based treatments on the order of 25 to 40%, depending on the study. All of us have been wondering, well, how does ketamine compare to electroconvulsive therapy? This was one of the first ever head-to-head comparisons of ECT to IV ketamine on an inpatient unit. This is racemic ketamine, which is what we give at CRTC, along with, of course, we give it IV. We also give it orally and to some extent intranasally. What was interesting is that when you look at the overall outcome, especially for people under 50, there was no difference between treatments. In fact, ketamine had an advantage over ECT in people under the age of 50. And with respect to relapse and recurrence rates, there were no differences between the two groups. So ketamine being a pharmacologic regimen, if you're able to demonstrate efficacy in the same conversation or comparable, at least in subpopulations to ECT, that's quite a statement. Obviously, the access and availability of ketamine is expanding, and its acceptance seems to be higher than what we see in many cases with ECT. Now, most of you have also probably heard that ketamine has been evaluated in suicidality, and esketamine has indication in the United States for depression and suicidality. And there are data showing that there are improvements within one infusion in suicidality, perhaps independent of its improvement in depression. And this is something that we have reported on at CRTCE. At CRTC, we are also interested in trying to identify, are there ways that we can synergize in the short term? Can we synergize in the longer term strategies that would provide a more robust and more enduring effect? It's interesting that there are data now showing in animal models that lithium in combination with ketamine may have additional advantages with respect to creating a less depressed rat. Well, does that translate into humans? We just don't know, but there's a variety of strategies that people are looking at trying to, in fact, sustain this benefit, improve this benefit, and this is what we're looking at CRTCE. These are some further data supporting the anti-suicidality effect. More recently, our medical director, Josh Rosenblatt in Toronto, who is overseeing the Ontario centers, has a really intriguing grant looking at IV ketamine in bipolar depression. We have a separate grant looking at IV ketamine in combination with CBT to treat suicidality, and we thank the CIHR for those grants. Now, I won't go through all the adverse events. I would just say that generally speaking, sub-anesthetic doses of ketamine are certainly very well tolerated and have been safe. And these are just the categories of adverse events that can be observed and or reported. I won't get into all the details of these. Maybe Hani can speak to some of these, but we've been certainly very pleased with the degree of tolerability and safety that we are seeing, with less than 1 or 2% of people really having significant adverse events that would encroach on acceptability of the treatment. So it's been a very acceptable treatment without sexual dysfunction and weight gain and without cognitive dysfunction. In fact, Hartej Gill one of our graduate students doing his PhD with us summarized the extant literature. And what's interesting is that there is a signal. It's a signal. It's not an unequivocal signal. It's not a proven signal. It's a signal that ketamine in depression might have pro-cognitive effects. And that would be interesting because that's such an unmet need, but it also goes against what I had observed in my career. I've had patients who've abused ketamine, who are polysubstance abusers, who clearly had anti-cognitive effects. But when ketamine is used in sub-anesthetic doses, it does seem to be highly pro-cognitive in animals, and there's a hint that might also be the case in humans. And I would conjecture that may play a role in the anti-suicide effect, as well as improving measures of hedonic tone. I have struggled with treating anhedonia in my career, and this treatment seems to help. What about kidneys and bladders? You all know about ketamine-induced urological toxicity. We just don't see it. There's no reports of this with S-ketamine or ketamine. It's something we are aware of in the substance abuse literature, but not something that we are seeing. So taken together, we've had now over 5,000 treatments at CRTC. We've really accrued a tremendous amount of experience, but most importantly, we've really, in fact, been addressing the prerogative, that's to help the prerogative of depression and suicidality with benefits that for our patients that have been very, very rewarding indeed. So with that, I just want to stop there. A very quick overview of ketamine. I want to pass the floor now over to Hani.
Hello.
Hi, Hani. We can hear you well. Good to see you. The floor is yours.
So you have my screen?
Yep, everything looks good, Dr. Iskandar.
We can see it.
OK, bonsoir tout le monde. Comme Dr. McIntyre vous a présenté une introduction pour ce qu'on fait au CRTCE, je vais aller avec vous dans quelques détails pour voir les nouvelles opportunités de traitement pour les personnes souffrant de dépression quand le traitement initial n'a pas réussi. Ça, c'est mes divulgations. Et puis, les objectifs en résumé, peut-être, définir et opérationnaliser les traitements de la dépression résistante en première ligne et en milieu psychiatrique, réviser les meilleures pratiques des prochaines étapes de traitement quand les approches initiales n'ont pas réussi et réviser les données de la kétamine dans le traitement des adultes avec un diagnostic de dépression résistante au traitement. Dr. McIntyre a fait un peu le vol d'oiseau sur ces quelques points. Moi, je vais aller dans les détails. Qu'est-ce qu'on fait vraiment au CRTCE? Excusez, je ne veux pas traduire le Canadian Rapid Treatment Center of Excellence. Je vais les laisser CRTCE. Donc, ça, c'est juste pour vous dire c'est quoi CRTCE. La première clinique au Canada qui offre les traitements de dépression réfractaire avec la kétamine est déjà en service depuis plusieurs années. Dr. McIntyre a mentionné que nous avons 4 cliniques, 2 à Toronto, une à Ottawa, une à Montréal, plus de 80 membres du personnel et plusieurs centaines de patients. Il y a toujours la recherche et continue d'autres alternatives pour les traitements rapides de la dépression résistante comme les psychédéliques. Et vous savez très bien qu'il y a du retard quand on traite un patient avec la dépression. Ça prend toujours 2 semaines à 4 semaines. Et c'est pour ça qu'on cherche de nouvelles alternatives pour des traitements rapides. Plusieurs plans pour l'expansion et le développement de services sont en cours. Alors, comment recommander un patient au CRTCE? Premièrement, il faut aller remplir le formulaire sur le site web du CRTCE Montréal et vous l'avez sur l'écran. Et si vous pouvez regarder à votre droite, ça, c'est ce que vous allez trouver dans le site web. Et puis après ça, vous avez cliqué où il y a le cercle ici, vous allez presser sur ce bouton-là pour dire référer un patient. Envoyez le formulaire dûment rempli. Et j'ai souligné le mot dûment parce que nous avons vraiment des références de collègues qui se limitent à 2 mots, comme par exemple, patient déprimé, s'il vous plaît voir, et c'est tout. Alors, je ne crois pas que c'est gentil de votre part de nous écrire juste ça. Il faut le patient qui souffre de dépression, ça fait longtemps, donc il doit y avoir une petite histoire derrière lui. Alors, s'il vous plaît, écrire un peu plus et nous donner une idée de ce qu'il prend comme médicament. Le patient doit remplir le formulaire d'inscription et il est recommandé aussi qu'il écoute aussi le cours vidéo d'information. Ça aide beaucoup les patients quand ils regardent ce vidéo. Et puis, on va faire l'évaluation du patient. Je ne vais pas aller beaucoup dans les détails des critères d'inclusion. C'est sûr qu'âgé de moins de 18 ans, un consentement éclairé, et il y a une évaluation médicale, ça c'est sûr. Le patient a un diagnostic primaire d'épisode dépressif majeur dans le cadre défini par le DSM-5 ou d'un trouble bipolaire. Aussi les personnes avec un trouble de stress post-traumatique, etc. Toutes ces personnes-là, nous allons faire l'évaluation de ces personnes. Et les personnes aussi peuvent avoir des troubles psychiatriques comorbides, mais l'état psychiatrique comorbide ne peut pas être ni l'état primaire ni le principal sujet de préoccupation clinique. Alors, les personnes qui ont reçu une thérapie électroconvulsive et une autre thérapie neuromodulatrice seront admissibles à la perfusion à la kétamine. Les critères d'exclusion maintenant, il faut faire attention que c'est un protocole de traitement assez restreint, donc on suit vraiment les règles pour qu'on ait quand même une sélection de patients qui peuvent en profiter. Les personnes qui répondent aux critères du DSM-5 pour un trouble lié à la consommation et de drogue, le trouble lié à l'usage de substances et les personnes qui utilisent des substances illicites et les personnes qui éprouvent des symptômes psychotiques, souffrant de troubles de démence et n'ont pas en mesure de fournir un consentement de traitement écrit, les personnes qui ne sont pas en mesure de respecter le protocole dans sa totalité à cause du temps à respecter, etc. Aussi, les personnes incapables de désigner une personne pour assurer leur transport, parce que c'est très important. Les personnes présentant un traumatisme crânien, les troubles médicaux non contrôlés, la grossesse et les contre-indications médicales à la kétamine, par exemple, j'ai mis l'épilepsie, les patients qui pèsent plus de 275 à 300 livres, c'est une contre-indication et un critère d'exclusion. Tout patient qui n'a pas de médecin traitant ne sera pas accepté. Ça, c'est très important parce que nous, quand on termine des traitements avec la kétamine, il ne faut pas laisser le patient comme ça. On ne fait pas le suivi à vie. Tout patient qui ne se sent pas bien pour une raison quelconque, par exemple des symptômes de contact avec une personne malade d'une infection transmissible. Donc, en bref, je vais aller vite dans ça. Je vais aller dans la kétamine. Le kétamine est un antagoniste MDR utilisé La kétamine est un antagoniste en MDA utilisé cliniquement en anesthésie, non indiqué pour le traitement de la dépression. Nous, on fait usage off-label, plusieurs références comme Dr. McIntyre a présenté, et le mécanisme d'action, en effet, antidépresseur demeure un sujet à controverse, mais en général, la kétamine exerce ses effets antidépresseurs en modulant le système glutaminergique. Le mécanisme d'action de prévention du suicide et de la dépression de la kétamine peut être dû aux concentrations de glutamate sérique après l'activation des récepteurs AMP1. Donc, c'est juste pour vous donner une idée, quand vous savez que la kétamine est utilisée en anesthésie, l'induction de l'anesthésie, c'est 1 à 2 mg per kilogramme. Et puis, la sédation et une analgésie pour les patients intubés, c'est 5 à 30 microgrammes per kilogramme par minute. L'analgésie pour les patients non intubés, 1 à 5 microgrammes par kilogramme minute. Alors, dans la dépression résistance au traitement, on commence par une dose de 0,5 mg par kilogramme en 40 minutes. Ça, c'est le nombre de publications qu'il y a eu depuis les années 1975. Ça a été publié au British Journal of Psychiatry en janvier 2022. Comme vous voyez, les publications augmentent chaque année et comme vous voyez, on est arrivé à presque 140 publications pour 200 en 2021. Les indications de la kétamine, on a le trouble dépressif réfractaire ou résistant, trouble obsessif compulsif, la dépression bipolaire, l'abus d'alcool, la cocaïne et les opiacés, le trouble des conduites alimentaires, le haut risque suicidaire, le stress post-traumatique, l'anxiété sociale ou l'anxiété généralisée. Le piège du trouble de la personnalité. Disqualifier un patient à cause d'un trouble de personnalité comorbide et discriminatoire sans aucune base de preuve. S'il remplit les critères d'un trouble dépressif majeur avec d'autres critères éligibles, le patient est admissible au traitement à la kétamine sans se soucier du trouble de la personnalité ou les traits de la personnalité comorbide, toujours traiter la comorbidité. Les guidelines de la kétamine en 2021, ça a été reporté par les CANMAT. Les patients souffrant du trouble dépressif majeur ont souvent une réponse limitée au traitement. Pour la première et la deuxième intention, donc de nouveaux traitements pharmacologiques sont nécessaires pour la dépression réfractaire. La kétamine, un antagoniste des récepteurs N-méthyl-D-aspartate, a démontré des effets antidépresseurs rapides chez les patients DAT. Donc, nous avons quand même un guideline qui va être renouvelé et pour mettre les derniers résultats de la littérature. Les facteurs à considérer pour le traitement à la kétamine. Premièrement, le niveau de la résistance de la dépression au traitement, le nombre d'essais pharmacologiques adéquats, c'est ça que je voulais vous mentionner depuis le début. Combien d'antidépresseurs le patient a essayé? Est-ce que c'était pour un temps adéquat avec des doses thérapeutiques? La présence du suicide aigu, la présence de comorbidités physiques ou psychiatriques, et s'il y a eu une réponse antérieure à la kétamine, et s'il y a le risque d'abus, la dépendance à la kétamine ou le risque de diversion. Dr. McIntyre a présenté un peu une idée du STAR-D, la fameuse recherche qui a coûté 35 millions de dollars américains, qui était pour 6 ans. Une très bonne étude qui a été faite, quand même. Mais alors, ce qu'on peut voir ici, c'est que les traitements alternatifs en séquence pour soulager la dépression, comme vous voyez, le pourcentage de la population originale qui est demeurée symptomatique, regardez, en commençant avec le citalopram, en augmentant avec le bupropion et le buspirone et le CBT, la psychothérapie ou le switch, 44% au niveau 3 et au niveau 4, 39%, et le switch a été fait pour un IMAO, venlafaxine XR et mirtazapine. Donc, un grand pourcentage de patients sont non répondants ou partiellement répondants. Donc, on a de pauvres résultats après échec de 2 à 3 médicaments. Ça, c'est pourquoi on exige un échec de 2 antidépresseurs pour qualifier le traitement. Ketamine infusion made easy, c'est pas facile. Tout le monde croyait que c'était une corvée de faire ce travail de l'infusion. Non, c'est simple. Choisir le bon, on va aller ensemble pour comment choisir le patient, etc. et avoir un peu plus de détails. Si je vous donne le parcours du patient au CRTCE, donc on a ici une photographie de 4 doses, donc le premier jour, le 4e jour, le 7e jour et le 11e jour. Alors, la référence en ligne, comme je vous ai dit, le patient doit écouter les vidéos d'information au CRTCE, la rencontre avec le médecin du CRTCE pour l'évaluation, demander les questions et l'information nécessaires. Un consentement éclairé et questionnaire médical doit être signé. Et après ça, contacter et consulter la compagnie d'assurance s'il a besoin. Prévoir une personne pour accompagner le patient. Donc, ça, c'est le parcours du patient lui-même. Alors, avant les infusions, on fait l'examen physique, on s'assure qu'il y a un examen physique récent, indice de masse corporelle et poids, les signes vitaux, EKG, l'analyse d'urine, résultat des échelles de base qu'on va discuter ensemble dans quelques secondes, et la révision des traitements actuels. Donc, imaginez que le patient arrive avec du venlafaxine 75 seulement. Alors, il y a un peu de benzo à côté et peut-être parfois si on peut trouver de l'aripiprazole 1 mg à 2 mg. Donc, il faut réviser tout ça pour solidifier un peu le traitement qui va servir après les traitements initiaux de la kétamine. Et le consentement éclairé doit être signé comme ça en début. Les échelles, je vais aller un peu vite dans les échelles. Vous connaissez le PHQ-9, on fait le GAD anxiété, on fait le quiz SR, self-report, ça c'est celui de la dépression qu'on utilise après chaque infusion. Vous allez voir ça. Nous avons aussi le MARS, on va voir ça. Le PGI, c'est le Patient Global Impression. Le KDSS, l'échelle de dissociation et l'effet secondaire post-infusion. Donc ça, c'est l'image du GAD7 que vous connaissez probablement. C'est très simple, le patient le fait et puis on fait le score et on garde ça exactement pour avoir une idée si l'anxiété est intense, moyenne ou sévère. Le MARS, ça c'est une échelle que le patient il répond. Et après ça, le quiz SR, comme vous voyez, c'est très important cette échelle-là parce qu'on l'a fait après chaque infusion. Et comme vous voyez, il y a 16 questions. Alors, le patient le fait après chaque infusion. Dans l'autre test qui est important et qu'on fait aussi, ça c'est pour le monitoring des symptômes dissociatifs. Alors, c'est 6 questions seulement et je ne vais pas aller dans les détails de ce test, mais par exemple, pour voir la déréalisation, la dépersonnalisation et l'amnésie. Donc, on demande 6 questions pour voir si le patient a été dans un état de dissociation ou de dépersonnalisation. Très important à retenir avant les infusions intraveineuses. Donc, on parle de repas, 3 heures. Il ne faut pas que le patient ait mangé. Les liquides pendant 1 heure. Nausées et risque d'aspiration à cause de ça. Cannabis et alcool 1 semaine idéalement, ou 3 mois idéalement. Les benzos et les Z-drugs 12 heures avant les infusions. Le lamotrigine, 8 heures. On parle de lamotrigine et de l'épival aussi. Et on parle aussi ici des anticonvulsivants comme le gabapentin, par exemple. Le naltrexone, 24 heures. Les IMAO, c'est 2 semaines parce qu'il y a un risque de syndrome sérotoninergique. Les stimulants, 48 heures pour qu'il n'y aurait pas de risque de crise hypertensive. Donc, le jour de l'infusion, le consentement a été signé, le paiement a été fait. Le patient arrive 45 minutes avant le traitement. PPE et COVID protocole à respecter. Des échelles sur l'iPad à compléter. Donc, on parle de quiz au CSR. L'infusion de 40 minutes, puis après ça, 15 à 30 minutes de récupération. 2 heures de surveillance pour les patients traités avec l'intranasal et le sous-lingual. Et chaque patient devrait avoir un accompagnateur pour retourner chez lui. Le changement de dose, on commence, comme je vous ai dit, à 0,5 mg par kilogramme. Le médecin responsable peut autoriser les changements de dose selon le protocole. L'augmentation de la dose est basée sur le manque de réponse aux infusions 1 et 2 et selon le résultat du quiz. Par exemple, moins de 20% de réduction sur le quiz. Dans quelques circonstances, le médecin traitant peut augmenter la dose de la kétamine même s'il y a plus que 20% de réduction observée sur le quiz. S'il y a un problème de tolérance à la dose utilisée dans les infusions précédentes, on peut diminuer la dose et l'ajuster selon le besoin du patient. Après la 4e dose, on va rencontrer le patient pour évaluer qu'est-ce qu'on fait pour la 5e dose et la 6e. Et quelle dose exactement le patient il a besoin pour maintenir ce qu'il a gagné durant les infusions précédentes. Ça, c'est une idée des effets secondaires, vite, nausées, étourdissement, dépersonnalisation, déréalisation. Ça ne dure pas beaucoup longtemps, d'après ce que j'ai vu avec mes patients. Le plus important, c'était la nausée et l'hypertension. Il y a une chose importante ici, tout le monde croit que si on a une dissociation assez importante, donc l'effet du kétamine est efficace, c'est vraiment efficace la kétamine quand il y a eu beaucoup de dissociation du patient. C'est vrai, c'est pas vrai. Non, c'est pas vrai. Alors, vous n'avez pas besoin de dissociation pour obtenir les effets antidépresseurs de la kétamine. Les effets antidépresseurs de la kétamine ne s'appuient pas sur une révélation dissociative ou une perspective de gain de bénéfice. Donc, c'est une opinion erronée. Donc, on a ici une étude qui juste nous résume un peu les gains qu'on a vraiment. Et si vous regardez le quiz en haut, à gauche, en haut, si on a le baseline est ici, vous voyez après la première infusion, la deuxième, la troisième, il y a une évolution du quiz. Donc, et ça s'améliore dans plusieurs autres étapes ici, comme vous voyez dans l'anxiété, dans le suicide ici, etc. Donc, vraiment, on a une amélioration bien démontrée après la 3e infusion. Ici, l'augmentation le changement dans l'échelle de matrice durant les 15 jours de la phase double insu dans une étude de kétamine intraveineuse dans le TRT. Donc, comme vous voyez ici, ça, c'est 2 infusions par semaine. Voilà. Et ça, c'est 3 infusions par semaine. Vous voyez, ça descend quand même l'amélioration. Mais ici, l'échelle qui a été utilisée, c'est le Montgomery-Åsberg Depression Rating Scale. Donc, quand même, on a une amélioration dans les 2 semaines. L'efficacité dans la dépression bipolaire, je regardais le schéma C, comme ça on peut aller plus vite. On peut voir la réponse en rouge, post-infusion 1, post-infusion 2, post-infusion 3 et post-infusion 4. Les colonnes en bleu démontrent la rémission vraiment. Et quand on dit rémission, donc on n'a pas de symptômes presque. Et le quid ici, et il enregistre plus ou moins -5. Il n'y a pas, dans ces traitements, il n'y a pas eu vraiment de l'hypomanie observée que juste dans 3 patients sur 47, et il n'y a pas eu de manie flagrante ou un switch assez en psychose ou en manie. Donc, juste 3 cas sur 47 observés avec hypomanie. La kétamine sous-linguale est plus biodisponible, 30% par exemple, que la kétamine orale qui est 20% seulement. Donc, on n'utilise pas la kétamine orale, elle n'est pas recommandée pour le moment. Les doses 0,5 mg par kilogramme et 1 mg par kilogramme IV, on peut les comparer à 1,5 mg par kilogramme et 3 mg par kilogramme sous-lingual. Les patients qui ont répondu à la kétamine IV ont eu besoin de doses de maintien. Donc, ce qu'on fait, après la 6e infusion, on demande aux patients quel genre de maintien voulez-vous. Et la plupart des patients choisissent de faire un switch à la kétamine sous-linguale. C'est sûr, en maintenant la psychothérapie et en maintenant les médicaments que le patient prend. C'est très important. À noter que le temps moyen de rechute est à peu près 18 jours. La kétamine sous-linguale peut fournir une alternative fiable, accessible pour les patients bien sélectionnés. Donc, on fait le suivi après la 4e dose et après chaque 2 doses. Donc, par exemple, kétamine 1 fois par semaine pour 3 semaines ou 1 fois par 2 semaines, etc., dépendant du besoin du patient. Ça, c'est juste un résumé assez important. Donc, vous voyez, la non-réponse, c'est à peu près 40%, comme Dr. McIntyre avait mentionné. Nous avons une réponse partielle à 25%, la réponse complète à 20% et la rémission à 15%. La question que tout le monde se pose, est-ce que la kétamine crée-t-elle une dépendance? Bien connue comme une drogue de rue avec différents noms, comme vous voyez, Special K, Kit Kat, Vitamin K, etc. La kétamine a un rythme de capture très bas, moins de 3%. Alors, c'est pour ça que nous avons un trouble à l'usage d'une substance, c'est moins de 3% pour développer un trouble de l'usage. Quand administré dans une clinique et sous supervision, il n'y aura pas d'occasion d'abus et de mésusage. La kétamine IV peut être une drogue de sortie, on appelle ça exit drug, diminuant le besoin d'usage d'alcool et de cocaïne quand combiné avec des interventions et du counseling en dépendance. Donc, beaucoup de gens supposent que la kétamine ne crée pas de dépendance, mais il est vrai qu'elle ne crée généralement pas de dépendance de la même manière que l'alcool ou l'héroïne, car la dépendance à la kétamine est de nature plus psychologique et moins physique. Cependant, les utilisateurs peuvent développer une tolérance à la kétamine relativement rapidement, c'est-à-dire qu'ils ont besoin de plus en plus de la drogue pour obtenir les mêmes résultats. Je vous laisse avec ces informations-là. Merci de votre attention. Ça, c'est un livre qui s'appelle « Ketamine for a Treatment Resistant » qui a paru l'année passée. Très intéressant. Il a été édité par Carlos Zarate et Gustavo Vasquez, si quelqu'un est intéressé. Et je vous laisse à Matt pour les questions. Merci.
Perfect. Thank you so much, Dr. McIntyre and Dr. Iskandar. So for the Q&A, I'm going to go through the chat here. Dr. McIntyre, if you don't mind answering the questions that we have in English, and then Dr. Iskandar, if you don't mind answering them in French afterwards. A couple of the questions may have been mentioned in the French portion of the presentation, but there's several people who didn't realize the presentation was in French. So I think what we'll do is just answer the question systematically, and that would be the best way to handle it. So Roger, if you're ready,
Yeah.
can you comment on the use of psilocybin? Will it become more mainstream to treat treatment-resistant depression?
Yeah, it's a great question. Psilocybin has been receiving a lot of attention, not only from the medical profession, but also from the general population, the media. It's been covering it quite extensively, actually, the last 2 to 3 years. And no doubt people are receiving questions from their patients and their families. And look, nobody's unaware of the fact that psilocybin and related molecules like LSD and ayahuasca, ibogaine, DMT, there's many of these medications that are under the broad banner of psychedelic. I think to keep it brief, what I would say is at this point in time, there's absolutely no role whatsoever for psychedelics in psychiatry. There's no evidence at this point that they're safe, well tolerated, or effective beyond a reasonable doubt. Now, that being said, there are in fact lines of research right now, and there's been some publications of studies, especially with psilocybin at the macro dose, 25 milligrams or higher, that it could be safe, it seems to be tolerated, and it seems to be effective. Recently in Toronto, under Josh Rosenblatt's leadership, we've launched a study with psilocybin, and I don't have the slide with me right now, but I just will refer to it, that we have data now to show that we are, as part of a clinical trial, where patients are receiving psilocybin 25 milligrams twice a day. Of course, this is along with psychotherapeutic support and integration, are showing significant benefit and rapidly with depression. So in short, there is absolutely no role right now for giving people psilocybin to treat a mental illness. Secondly, it's being studied, and there are companies that are looking at this, and there's our organization that's looking at this. And I think really it should be confined to research protocols, to be perfectly frank. We're aware of the fact that there's special access authorizations, programs that the Canadian government has in place for people who have end-of-life illness and depression. And I think everyone's aware of that. But that's a different conversation than should we be giving it to people for depression or PTSD or anxiety, et cetera, et cetera. So stay tuned. It's a big question, doesn't lend itself to a soundbite answer, but I'm aware of the fact that there's many people who are giving it or recommending it to patients. I would strongly discourage that. It's a criminal offense to be doing that. That's one reason. And the second reason is that the evidence and safety is not there. It's a story that looks very promising, and we at CRTC are conducting this very large study right now with psilocybin, so hopefully we'll have some data before the year's end.
Perfect. Thanks, Roger. Dr. Iskandar, if you don't mind commenting in French.
Oui, pour les psychédéliques, je n'ai pas mis beaucoup d'informations sur ça, vu que c'est très restreint, comme vous savez. C'est très difficile aussi d'obtenir du gouvernement, n'est-ce pas, l'autorisation pour faire ça, sauf si c'est un protocole très restreint. Alors, on laisse notre clinique de Mississauga à faire ça, et après les résultats du premier protocole, on va voir si on pourra continuer dans les autres sites CRTCE.
Okay, perfect. How often can we use ketamine and the duration of therapy?
So am I going first in English, or how we're doing this, Matt?
Yeah, I think that's probably the best. And then
Okay.
if Dr. Iskandar's already mentioned this in French, then he can skip.
Yeah, that's a great question. So the frequency of administration typically is around 6 treatments, spanning say 3 weeks, 2 to 3 weeks, usually a few weeks for people, and that'd be called an acute treatment. And then the next steps are informed by how that first acute treatment protocol went. So for example, if the patient doesn't benefit at all during that time, then the patient would sit down with one of the clinicians and then map out a very different pathway going forward. If there is improvement, then in fact, the decision is then determined. These are obviously shared decisions with the patient. It brings up a lot of similarities with ECT. When somebody benefited from ECT, what are the next steps? And of course, that was always very personalized. But in the case of ketamine, we do have evidence now that some patients can sustain the benefit. And there was some data from a large controlled trial from Europe that supported that. But the fact is that a large percentage of patients will in fact require some type of booster or some type of additional treatment. And how frequently that is will be personalized and tailored to each individual. And frankly, I should not forget to mention that there's an interest in trying to sustain the benefit, not only with pharmacotherapy, but also with psychotherapy. Maybe psychotherapy could sustain the benefit, although that's not unequivocally proven just yet, but there's some promising data, for example, for CBT. But what we do at CRTCE is we offer ongoing and periodic boosters tailored to the individual. We've got some patients who've been coming for years for ongoing boosters. I think the first point is, Matt, we don't have any evidence of cumulative toxicity. We're not seeing any evidence of new onset safety concerns or important safety considerations. We haven't seen any new onset misuse or gateway activity, anything of that sort. And we continue to see in most people a sustained benefit of the treatment. So it's something that we're looking at, and certainly something that I think a sizable percentage of patients are going to require.
Perfect. Thank you, Roger. Dr. Iskandar?
Yes.
I believe this part of the presentation was answered in your talk, correct?
Yes.
Yes. Okay. Perfect. Thank you. Okay. The next question is, how much does the treatment cost, and is it covered?
Do you want to speak to that one, Matt? Do you have the numbers in front of you?
Yep, absolutely. So as of this time, the intravenous per infusion is about $850 per dose, and the sublingual treatment at this point is about $250 per dose. The vast majority of that cost at this point is with the clinical monitoring that has to take place with our staff. So we have psychiatrists, anesthesiologists, and nurses on site. In terms of the coverage, Blue Cross does cover it for veterans and active servicemen, and then there is some coverage with private plans, whether that be 80% or 100%. However, at this point, it's not covered by any of the publicly funded drug programs. Okay, so the next question that we have will be, what about the 60% of patients who did not respond to ketamine treatment? What about the old TCA and Afrinil IV bolus followed with a PO treatment?
Well, I think it's a really, really good question. And I think for colleagues who are on the call, again, I don't know most of our colleagues joining us tonight, and people have different backgrounds and experience, and some people are older and some are younger. But certainly, Hani, I think in our group, we remember the monoamine oxidase inhibitors. I remember them very fondly. I use them extensively. And the very first clinical research study I ever did, Matt, I took patients who didn't respond to fluoxetine. Then I gave them desipramine, which is the desmethylated imipramine metabolite. And then if that didn't work, I combined the two together. And that being fluoxetine and desipramine. So I have a research background combining tricyclics, and clinically, I think monoamine oxidase inhibitors, notably the irreversible non-selective, are probably underutilized in my opinion. So whenever I sit down with a patient, and by the way, just about everybody I see has not benefited from at least 2 antidepressants. Unfortunately, that's very, very common. I do mention to people that with respect to options, I do think monoamine oxidase inhibitors represent an option, and that's coming from me clinically. In combining tricyclics, notably imipramine, desipramine, nortriptyline, with a SSRI that does not inhibit the cytochrome P450 system is one I would consider. Why I think imipramine, desipramine, nortriptyline is because we can do therapy to drug monitoring with those TCAs. But taken together, tricyclics and monoamine oxidase inhibitors, two categories of medicines I prescribe a lot still, they just haven't been subject to the same rigor of study in treatment-resistant depression as has some of the newer treatments, some we don't have in Canada, but what we have in Canada, of course, being ketamine. So I do think, in fact, that there are options, but the rigor is simply just not there for treatment-resistant depression as it is for what we're seeing with ketamine. Final point is that, again, I certainly am an enthusiastic prescriber of MAO inhibitors and tricyclics. They don't work as rapidly as what we're talking about. And certainly in patients who have very severe treatment-resistant depression, they're not as effective. One final point, Matt, is if someone does not respond to ECT, they typically do not respond to TCAs and MAO inhibitors. In fact, Harold Sackheim showed that convincingly from Columbia. But if you don't respond to a MAO inhibitor and tricyclic, that has no predictive bearing on ketamine. So the point being is I think that we're talking about a very different situation with ketamine.
Matt, can I make a comment on that? Adding to what Rogers mentioned.
Yep, of course.
If they don't respond to ECT, they are not going to respond to the anafranil IV. My experience with that is we left it only for the severe OCD cases. And even with that, we didn't get more than 30 to 40% of success with the IV anafranil.
Perfect. Dr. Iskandar, do you mind just quickly summarizing Roger's points in French for our francophone members?
Oui, juste en résumé de ce que Dr. McIntyre a présenté, la question était qu'est-ce qu'on fait avec les 60% qui ne répondent pas à la kétamine? Qu'est-ce qu'on fait avec les anciennes tricycliques comme le disipramine, etc.? Et aussi, qu'est-ce qu'on fait avec l'anafranil IV? Alors, en résumé, Rogers, il utilise, tout le monde en a utilisé les tricycliques au maximum, comme vous savez. Les gens qui ont fait des ECT et qui n'ont pas réussi aux ECT, les tricycliques ne vont pas répondre parce qu'il n'y aura pas de succès avec. L'anafranil IV, et nous, on l'a utilisé juste pour les troubles obsessifs compulsifs. Les combinaisons avec les tricycliques et les IMAO, ça se peut les faire, mais il faut avoir de l'expérience à les faire. À part ça, comme vous savez, le traitement résistant à des gens qui ne répondent à rien, alors on utilise une combinaison de beaucoup de choses. Merci.
Perfect. Thank you so much, Dr. Iskandar. I have a couple of questions here that I received via email. Just give me one sec. Okay. Dr. McIntyre, wondering if you could comment on ketamine-assisted psychotherapy and its use in therapy.
Yeah, that's a really great question. I think this is an example of where we need to have clarity on what we're talking about. And let's just define what we mean by ketamine-assisted psychotherapy. First of all, I have not seen a consensus definition of what that actually means. And so when speaking to different colleagues and different researchers in the area around the world, I've noticed that people have a different interpretation of what that actually means. For many people, and I was on a call just a couple of days ago with a colleague about this, what they understood ketamine-assisted psychotherapy to mean is that the patient would take ketamine, and under the influence of ketamine, the patient would be engaged in psychotherapy. So, Matt, it was something akin to the effect of taking a drug and under the influence of drug, perhaps by reducing psychological barriers or dissolving ego structures, that would facilitate or enable access to underlying emotional aspects and other types of aspects. There is absolutely no evidence at all that that is safe There's no evidence that all of that's well tolerated, and there's no evidence of all of that actually works. Now, that's a different conversation than someone who would go for ketamine, and let's say after ketamine, they then subsequently engage in manualized-based psychotherapy. That's, so a few days later, or whatever the case may be, they start psychotherapy. And that's a very, very reasonable consideration. A colleague of ours at Yale has done some work showing that that approach, that sequential approach, may in fact prolong the benefit of ketamine, which was achieved acutely. So a non-pharmacological alternative to sustain the benefit. I made reference very quickly, Matt, to a study we have at CRTCE sponsored by CIHR, where we're combining ketamine with cognitive behavioral therapy to reduce suicidality and sustain it to a greater effect. In other words, can we alleviate ketamine or alleviate suicide rapidly and then sustain it with CBT? And that's the thinking. But again, the CBT is not given while they're taking ketamine. It's given after the ketamine is completed. So taken together, I think ketamine-assisted psychotherapy does deserve a definition. My own definition of it would be that the patient takes ketamine, and then with alleviation of the depressive symptoms, they would then be better suited to then benefit from the practice and plasticity of psychotherapy. That heuristically makes sense, and there's some data to support it, and that's a study we're actually doing. But ketamine taken and then psychotherapy at the same time, there's no good evidence of that. And in fact, that is counterintuitive to me, insofar as our experience has been, and no surprise, that under the influence of the substance, the person's not able to really engage the psychotherapy in that sense.
Perfect. Thank you, Roger. Dr. Iskandar, can you give a summary in French, please?
Juste pour résumer ce que Roger a dit, vraiment, la psychothérapie en assistance à la kétamine, lui, comme vous savez, il n'y a pas de définition. Qu'est-ce que c'est exactement? Il n'y a pas de résultat. Lui, il ne suggère pas que la kétamine doit être faite en même temps. La psychothérapie doit être faite en même temps que la kétamine. La meilleure des choses, d'après ce qu'on a vu dans nos cliniques, c'est d'utiliser la psychothérapie après les traitements à la kétamine. Il y a une étude actuellement au CRTCE qui a été parrainée par le CHR. C'est le CBT, ou les traitements psychothérapie cognitivo-behaviorale, à réduire le suicide et la suicidalité. Et c'est ça, elle est en cours actuellement. Mais tant qu'on n'a pas exactement une définition de la psychothérapie assistée à la kétamine, on ne pourra pas se prononcer sur ça.
Perfect. Thanks, Dr. Iskandar. This next question, I believe, will just be for Dr. McIntyre, just because I believe Dr. Iskandar answered this in his presentation. Dr. McIntyre, how does ketamine work? What chemical transmitters does it work on?
Yeah, it's a great question. I think Hani, I don't speak French fluently, but I agree with Hani what he covered there. And I think, first of all, we start off with a bit of humility, Matt. The mechanism of action, or the mechanisms that govern the treatment response of ketamine, are not fully known. So it remains certainly very hypothetical. But what's not hypothetical is that ketamine does affect glutamate, and it targets select glutamate systems. And simply put, what happens is, and the theory is that by engaging glutamate, you are alleviating depression. Well, that seems overly simplistic to me. Again, going back to what's not a theory, there are really, in fact, a couple of processes that are set in motion. So imagine when ketamine is administered, it binds to a glutamate receptor, and that initiates a cascade of molecular events. And these molecular events result in an increase in trophic factors and other factors that stimulate neurogenesis. So what you witness at the cellular level is you see neurogenesis. At the more circuit and network level, you begin to see more evidence of plasticity enhancement. So by initiating a cascade of events, the ultimate, the consequence is you get an increase in trophic factors, an increase in neuroplasticity. Now, someone might be saying, well, that's kind of interesting because that sounds similar to other antidepressants and even physical exercise and CBT. And I would say, yes, there's actually some points of commonality there. But you know, Matt, what's different is that you begin to see this effect on neurogenesis and neuroplasticity within one dose of ketamine, not 4 to 6 weeks of ketamine, one dose. So that might be the neurobiology that is governing or subserving what we're seeing clinically. And that's very interesting indeed. Some on the call who particularly like this area, you all know BDNF, brain-derived neurotrophic factor. That's only one protein that's increased in expression immediately after one dose of ketamine. There's another one called mTOR, which is the mammalian target of rapamycin. It's one that's also increased very significantly after one dose. And these two proteins result in neurogenesis and neuroplasticity enhancement. So I think it remains an unknown, Matt, and I think, but what's not an unknown is it does initiate this cascade of events that does result in neurogenesis and plasticity very, very quickly. So it's an interesting story, and it certainly is shared in common with some glutamate drugs, but not others. One related point to that, Matt, is many colleagues have asked a really good question, and that is, well, if ketamine affects glutamate, does that mean that all drugs that affect glutamate could be antidepressant? And we think about drugs like memantine or lamotrigine, and we have many, many other drugs, serine and glycine. There's so many drugs. Maybe I'll just be very brief and say, not necessarily. We have 3 ion-based ketamine receptors and 8 so-called metabotropic receptors. And without getting into all the receptors, it's too late in the day. What I would say is you have a complex set of permutations and combinations of interactions. Memantine, a well-known glutamatergic drug, has proven not to be an antidepressant, and lamotrigine has proven not to be an antidepressant in major depressive disorder, although it works in bipolar disorder. So if you're glutamate, that doesn't necessarily mean that you are in fact going to be antidepressant. So it does matter, the details matter. Final comment, we do know in the United States there's a isomer of methadone that is a glutamatergic NMDA antagonist that is not abuse liable, that's being developed as an antidepressant. And there's a new drug which the FDA is going to approve very, very soon. Is the combination of bupropion with dextromethorphan. Everyone remembers dextromethorphan, DM, the antitussive. It also has NMDA properties. So you are seeing new glutamate drugs coming out, repurposed glutamate drugs, but just because you're glutamate doesn't mean you're antidepressant.
Perfect. Thank you, Roger. Dr. Iskandar, anything to...
Un petit commentaire, juste pour, je ne veux pas résumer ce que Roger a dit, c'est un peu complexe, mais moi, je peux vous dire un petit résumé que je me suis fait juste pour faciliter ma tâche aussi de comprendre. Donc, le NMDA, s'il y a un effet antagoniste, nous avons un effet antidépresseur, et c'est là où ça vient les dissociative states, ou les crises de dissociation. Donc, ça, c'est le NMDA. Si on parle du AMPA, le récepteur AMPA, donc ça, nous avons aussi l'effet antidépresseur. Le système opiacé, par exemple, le mu, le récepteur opioïde mu, donc ça, c'est un agoniste qui est faible, il va donner un effet antidépresseur et un effet analgésique. Et ça, peut-être, c'est là où l'euphorie revient avec ce récepteur. Du point de vue alpha-1, le récepteur alpha-1, l'effet agoniste, c'est ça qui nous donne l'effet antidépresseur, mais aussi il nous donne les effets cardiaques, comme je dis, l'hypertension. Les récepteurs GABA-A, un effet agoniste, ça nous donne un effet anxiolytique assez important. Et le mTORC1, comme Roger a dit, si on l'active, nous avons un effet neuroplastique.
Perfect. Thank you so much, Dr. Iskandar. I believe this will probably be our last question of the evening. But how many patients have been involved in Canada versus results in the United States in enrollment of ketamine treatment? Is there any discrepancy?
Wow.
I didn't get that question. Say it again.
Essentially, how many patients have been involved in Canada versus in the United States for enrollment of ketamine treatment? Is there any discrepancy?
Well, to be quite frank, I don't think that the answer is easily accessible because we don't really have a international, or for that matter, a centralized repository that would allow us to answer the question. In the United States, we've lost count. There's certainly more than 150, probably more than 200 clinics that provide ketamine, but they're not really coordinated or synchronized into a central database. I spend most of my time in the United States, and I can tell you that these clinics exist in small, medium, and large cities. So the answer doesn't exist. But what we can say is that in Canada, just simply based on, I can tell you firsthand, some of the process required to set these clinics up, to have expert personnel and to run these clinics. Matt, you'd know this, and Hani, of course, knows this firsthand. They're very difficult to do. And frankly, in the United States, there's a number of different aspects that are making it a little easier to set clinics up. So I think that Canadians, quite unfortunately, frankly, are not getting sufficient access to this treatment, in part because of the requirements in this country, which are quite extraordinary. And Matt, you made reference to this. They're very costly to be able to pay for the infrastructure, the materials, the what have you. So unfortunately, we have very few clinics in Canada, and so that's just what that is. But we've had over 5,000 treatments now, over 4 years now and counting. So we are pleased that we're able to provide this care, but we're also using our databases to inform not just our protocols, but to inform the global population on the appropriate use of this treatment.
Perfect. Thank you, Roger. Dr. Iskandar.
Je n'ai pas beaucoup de commentaires sur ça. La vérité, nous venons de commencer il y a juste presque 8 mois actuellement. Mais à cause de la sélection des patients, nous n'avons pas beaucoup de personnes jusqu'à date. C'est sûr qu'on augmente chaque jour. Alors, on va doucement, mais au moins, on est sûr qu'on fait un travail assez important pour les patients qui en souffrent et pour faire le service pour les gens qui ont des problèmes de dépression réfractaires ou réticentes au traitement.
Okay, perfect. Thank you so much, Dr. McIntyre and Dr. Iskandar.
Thank you. Merci à tous.
Thank you. Thanks,
so, everyone, thank you so much. If you have any follow-up questions, please go ahead and send emails to the montreal@crtc.com or ottawa@crtc.com. And a recording of the presentation will be made available later in the week. Thank you, everyone. Have a lovely evening.
Thank you. Thanks, Matt.
Thanks,
Hani.
Bye.
Thank you for joining. Take care. Bye-bye.